National Academy of Pediatrics, and we are going to hold this meeting in Chittaranjan Seva Sadan. Primarily, we need an introduction from our President, Dr. Shushmita Banerjee. So I request Dr. Shushmita Banerjee to kindly give a primary introduction of the program.
Good afternoon, friends, colleagues, seniors. Good afternoon. Welcome to this first clinical meeting of the WBAP academic program of 2022. As you all know, this clinical meeting has been a very regular program of WBAP. We have been seeing it from our student days, and we will be obviously carrying on with these monthly meetings. And I would hope that many more members and many juniors, many trainees will also participate, and all the different institutions will actively participate and show us their clinical cases. I think this is the most interesting way to learn from clinical patients, from clinical cases, to learn from practical problems, how to handle and how to proceed practically with all our many limitations and constraints that we have in our country. It is really a learning experience to see these cases and how they are handled. So we will have monthly clinical meetings for this whole year. In some of the months, we will also have two meetings a month, because we are trying to accommodate the big increase in institutions, in academic institutions that we have got in our state now. So for this first clinical meeting, I welcome all of you, and I thank the faculty and the trainees of Chittaranjan Seva Sadan, particularly Dr. Shubhashish Bhattacharya, Dr. Sudeep Saha, and we look forward to learning from your very interesting cases. Thank you.
Thank you, Dr. Shushmita Banerjee. It was rather an inaugural speech by our president, because this is the first clinical meeting that WBAP is doing this year, and it has been done by the Chittaranjan Seva Sadan, as we have already said. I would like to say a few words regarding our vision of the clinical meeting this year, that we do have all the medical colleges in our list for the clinical meetings as per their schedule, on the dates in which they are comfortable to do it every month. Along with this, we also have started the district, the peripheral clinical meeting this year. Though we are completely now full with all our dates, but still we have included a few of our district hospitals that have their own students as DNB PGTs, and we would like that the periphery also comes within the purview of our clinical meet, and for the peripheral clinical meets, we have to do a hybrid, do it in hybrid mode, and we will accommodate as many private medical colleges possible to do it. So this is this New Year's vision. Now let us see how many in practice we can do. Now in today's clinical meet, we are again starting the old tradition that we will have a judge, and the judges will see the program and give a note about it. So for today, judges Professor Kalpana Datta and Dr. Abhijit Datta. Professor Kalpana Datta happens also to be the vice president-elect of our WBAP, and Dr. Abhijit Datta is the scientific chairperson of WBAP this year. I welcome Dr. Professor Kalpana Datta and Dr. Abhijit Datta to change the judges' chair, and at the same time, I am not going into all the topics that are to be discussed today, and I am handing over the whole session to Dr. Professor Shubhashish Bhattacharya, who is also the moderator of today's session, and Dr. Sudeep Saha, who happens to be also one of the active members of today's clinical meeting, Chittaranjan Shivashankar. Over to Professor Shubhashish Bhattacharya.
Thank you, President and Secretary, West Bengal Academy of Pediatrics. Good afternoon to everybody, and welcome everybody at this first 2022 West Bengal Academy of Pediatric Clinical meeting at the CSS Kolkata. In spite of ongoing pandemic and recent surge of mutant strain, we could able to gather some interesting cases, clinical cases, for presentation at this meeting. During this pandemic, we are learning continuously about the new pathogen, which was non-existent 2.5 years back. This learning will continue, and in future, more and more pathogenesis of this new pathogen will be identified. My appeal to all learned members of the West Bengal Academy of Pediatrics, please encourage our postgraduates who have made all this in spite of most of them are down with the COVID recently. So with this introduction, I am going to my first case. The first case is a multiple serositis and hepatitis in a patient. Dr. Shreya Mukherjee, the second year PGT, will unfold the differential diagnosis and management of this case. Shreya.
Hello, Dr. Shubhashish and Dr. Sushmita. What is there should have equal marks distribution. I should talk to Dr. Abhijit. There will be 3 headings: timing, deliberation, and presentation and discussion. And the marks distribution they should be equal to me and Dr. Abhijit, you know?
Yes, I think you both of you are actually judging this.
It should be 10, 10, 10, 10, 40.
Out of 50.
Total 40, 10 for presentation, 10 for timing, 10 for discussion, and 10 for slide presentation.
Okay.
Abhijit, is that okay? No, Abhijit দাকে জিজ্ঞেস করছি, is that
না
okay?
টোটাল মার্কস কত? টোটাল মার্কস কত? হ্যাঁ, টোটাল মার্কস কি 40?
You can make anything. It should be equal distribution.
কল্পনাতে একবার অভিজিৎদার সাথে প্রাইভেটলি কথা বলেন দেবে?
সেটাই বলো, ও তো আছে।
নাম্বার আছে?
তোমাদের কি তোমরা বলে দাও, তোমরাও বললে হবে।
But at the end, if you both talk and then give us the results, it is better.
But okay, but we have to মনে থাকবে না তো পয়েন্ট করে করে লিখতে হয়। তো
সেই জন্য একটা ডাইরেক্টলি কথা বলে দিলে ভালো হয়।
হ্যাঁ,
ফোন নাম্বার আছে না? আমি ফোন নাম্বারটা পাঠাবো।
হ্যাঁ আছে, অ্যাকচুয়ালি গেলে তো আমাকে তো মোবাইল এটা এখান থেকে করতে হবে।
ওকে, ঠিক অফ কোর্স, ওকে। তো আমি চ্যাট বক্সে দিচ্ছি, হ্যাঁ? So can you just repeat the headings you gave?
First, the presentation. How she is presenting, timing, whether she has managed in time. Discussion point, and fourth is the slides. How the slides are prepared.
Scientific content রাখি।
Scientific content. Scientific presentation ঠিক আছে। Deliberation দিতে।
Scientific content presentation, second হচ্ছে PowerPoint slides.
Slides হচ্ছে, তারপর হচ্ছে timing, and fourth is discussion.
10 each, okay?
Then discussion.
Okay, thank you. We'll be starting. Dr. Shreya Mukherjee will be presenting the first case.
Good afternoon, everyone. Today I'll be presenting a case of multiple serositis. A 4.5-year-old female child, resident of KOLKATA, came to our OPD on 10th of January with presenting complaints of fever since last 3 days, cough for 2 days, generalized anasarca which started with facial puffiness and gradually involving the trunk and limbs since past 1 day, respiratory distress for 1 day, vomiting and pain abdomen for the same duration. The patient was apparently well 3 days back, after which she developed high-grade fever, 102 to 103 degrees Fahrenheit, intermittent in nature, accompanied with chills. Patient was playful in between febrile periods. There was periumbilical and right hypochondriac pain since last 2 days. non-bilious, non-projectile vomiting 2 to 3 times per day, mainly post-feed. There was no history of diarrhea, no history of decreased urination, no history of any joint pain, rash, convulsion. No past history of similar episodes, no history of hospital admission in past, and no past history of COVID-19 infection. On clinical examination, the child was conscious, alert, cooperative. There was tachypnea, tachycardia, surface temperature was raised, BP was in between 75th to 90th centile as per the age and sex of the child. Saturation was 92 to 93% in room air. Generalized anasarca was present. Air entry was slightly decreased on the right inframammary side of the chest. Subcostal suction was present. Per abdomen was soft but distended. Liver was enlarged. Liver span was 8 centimeter, soft, tender, and palpable 2 centimeter below the right subcostal margin. Heart sounds were audible and there was no murmur. From the history and the basic clinical examination, we kept nephrotic syndrome first episode, dengue, scrub typhus, pneumonia, autoimmune serositis, severe COVID, and MISC as our differential diagnosis. The patient was kept propped up and was started on moist oxygen, fluids, empirical antibiotic ceftriaxone was given, routine investigations were sent, and a chest X-ray was done. So the investigations till now, the rapid antigen test for COVID-19 came negative, COVID RT-PCR was sent, hemoglobin and total leukocyte count was slightly decreased, MPDA was negative, platelet count was decreased, and there was a very high CRP of 195 milligram per DL. The liver enzyme showed that SGOT was within normal range, and the urine dipstick showed 2+ proteinuria. As the patient had tachypnea, tachycardia, and hepatomegaly, we did a TROP-T which came negative, and ECG showed no abnormality. The chest X-ray on day 1 showed blurring of the right costophrenic angle. So keeping the possibility of MISC in mind, we had sent blood for COVID-19 antibody. COVID RT-PCR report was still pending, and an echo was done which showed no abnormality. On day 2, the patient complained of heaviness of chest on the right side. Respiratory distress by now had increased. High-grade fever persisted. Tachypnea, tachycardia persisted. Tenderness on the right hypochondrial periumbilical region was present, and air entry was decreased on the right inframammary part of the chest. Chest X-ray on day 2 showed that the pleural effusion had increased than the previous day. So, pleural fluid aspiration was done under aseptic condition, and the pleural fluid studied showed a transurative type of picture. Blood reports so far, we could rule out dengue, MPDA came negative, and scrub typhus report was also non-reactive. The ANA profile report was still pending. By this time, COVID-19 RT-PCR had come positive, and COVID-19 antibody was raised by about more than 20 times. As COVID RT-PCR test came positive, considering the patient to have severe COVID infection, the patient was started on injection Lasix, steroid was given, and the D-dimer was more than 5 times raised. So the patient was started on low molecular weight heparin at a prophylactic dose. As the patient had fever for more than 3 days, and there was evidence of coagulopathy by elevated D-dimer levels, acute GI problems as pain, abdomen, and vomiting was present. There was a very high CRP. No other obvious cause of inflammation could be found out, and COVID-19 RT-PCR and antibody came positive. So we could fit her in the MISC criteria, but as severe COVID and MISC has overlapping symptoms, so we were still in a dilemma whether the patient had severe COVID or MISC. By day 3, the blood culture report had come negative, and the patient had started improving. There was improvement in chest X-ray by day 4. There was no past history of being affected with COVID-19 or being exposed to patients of COVID was given by mother initially. But after further inquiry, the mother said that the history of fever and cough and cold was there in family members about 1 month back. The patient was already being treated as a severe COVID. By day 4, the patient had improved clinically. Tachypnea and tachycardia was corrected. Patient became febrile. The inflammatory markers and D-dimer were still in the higher range. And surprisingly, the liver enzymes got further elevated. The PT-ANA report which was sent was normal, and the blood for IgM-HAV was sent, which also came normal. Because the liver enzymes were so much elevated, we had then searched for literature, and we found a retrospective cohort study which showed that hepatitis is common in children with MISC and is associated with a more severe presentation and persistent elevation of the liver function tests in many. Further course during hospital stay, the patient had improved with treatment as per severe COVID guidelines. Patient gradually became playful, appetite had improved, repeat D-dimer came within normal range, so injection enoxaparin was stopped. Liver enzymes were still raised, steroid was continued for 1 week. As the patient had no further complaints and had improved clinically, so we could successfully discharge her after 10 days of hospital stay. During discharge, the liver enzymes were still elevated, and by this time, the ANA profile report came, which turned out to be negative. Now, the questions which remain unanswered are whether we can attribute the entire presentation to MISC, COVID-19 IgG being positive in such a high titer, maybe due to a previous infection when the patient was asymptomatic or mildly symptomatic about a month back with a very high titer of IgG positivity, along with COVID-19 antigen being positive, that too almost more than 20 times within 2 to 3 days is quite unusual. The Omicron variant causing a life-threatening MISC has not been reported yet in children, so it is tough to say whether it is too early for us to rejoice. Now, this is another case report showing that a patient had right-sided pleural effusion in a case of MISC, but however, the dengue IgM was also positive in this children. Now, the Omicron variant of COVID has more than 50 new mutations. It has a faster upstroke with a shorter incubation period and a shorter doubling time. The animal models show that it multiplies twice as fast than the other variants, has milder symptoms and disease, and the R0 value of Omicron is more than 7, which implies that it has a much higher transmissibility rate as compared to the other previous COVID variants. So what we learned from here is that whatever the initial presentation might be, in this pandemic era, COVID-19 should be ruled out first. Whenever there's a clinical suspicion, both antigen and antibody of COVID-19 positivity at the same time, that too in such a high titer of more than 20 times increase, presenting as generalized anasarca and serositis is very unusual. Thank you.
Thank you, Shreya. So, our judge, please, if you want to ask any question.
Yeah, one question from my side, Dr. Shubhashish. Did you see the different type of, like we know that different type of antigens are there in the delta, that is surface protein and non-capsulated and invalid protein NC. And if there's a surface protein is absent, there's a dropout, then we can think of it is a not delta, it's a Omicron. It could be the possibility the second was the Omicron positive and the antibody is because of the previous delta infection. So could you go have seen that all those proteins and genetic materials and all, because it can be seen even in the artificial method. We don't need the gene sequencing. We can have an idea. Did you see that?
No.
No. Just
no, ma'am, the gene sequencing was not done, so we are not sure that which variant was.
Gene sequence is quite costly. It's not done in each and every patient. It is a random choosing done in called AIMS Kalyani. But you can see the different type of antigens, that is S, N, and E. If there's a S is absent, that is called dropout, S dropout. We can suspect.
Yes, gene dropout. Yes, ma'am.
Okay.
Yes, ma'am.
But in this case, there is no S gene dropout. That is not mentioned in the government report because they are not doing all the reports. They are measuring the S gene and they are mentioning the dropout. That is, so it was not there in report.
Okay. So how will you explain that?
Should I go to the next case, madam?
There are a few questions in the chat box. If you can take them quickly. 2 questions.
Chat box. Is there any other question? Madam, we will discuss after at least 2-3 cases because otherwise I will not able to finish in time probably. So I am going for the second case. Our second case will be presented by Dr. Khairul, and he will be presenting a case of chronic diarrhea, how he approached and identified the cause and they treated. Dr. Khairul, please.
Hello, please mention the name of the second speaker.
Khairul Islam. Ma'am, Khairul Islam.
No video.
Hello, we'll be Dr. Susmita will be presenting because of some amount of technical glitches there. Sudeep is trying to fix it.
সোমনাথদা বোধহয় অডিও ভিডিওর কোনো প্রবলেম হচ্ছে কোথায় ওদের এন্ডে
ওদের ওখানে একটু প্রবলেম হচ্ছে সুদীপ সাহ ওটা রেকটিফাই করছে করে আবার আসবে
আচ্ছা ঠিক আছে
হয় না আসলে এবার
Sudeep, sort হচ্ছে?
হ্যাঁ সলভ হয়েছে
Okay, okay. আমরা দেখতে পাচ্ছি। You can start.
সাউন্ডের প্রবলেম কি এখনো মেটেনি?
You're still muted, Dr. Khoirul. Can you unmute? Yes, yes, this should be fine. Please start.
Myself, Dr. Khairul Islam. I'm going to present the case of chronic diarrhea confronting the losses. Presenting complaint, a 2-year male child, second by birth order, born of non-consanguineous marriage, admitted with the chief complaint of watery loose stool on and off for 1 month, multiple episodes of vomiting for 2 days, no history of blood mucus mixed with the stool, no history of fever and pain abdomen. The first history similar complaint associated with lower respiratory tract infection, 1 month back, require hospitalization for 10 days, receive IV antibiotics and special diet for malnutrition. Thereafter, he developed a deep-seated abscess around the knee joint and required surgical incision and drainage. Since then, the symptoms of loose stool began and persist till now. and also the failure to gain weight since 1 year, in spite of giving the treatment 1 month back, but the weight remains same around 7 kgs. No history of food associated with diarrhea, developmental history appropriate with age, and immunization up to date. And looks, this is the look of the baby before 1 year of age. The growth of the weight gain and growth of the child is normal. And now come to the examination. On baby shows a significant pallor and angular stomatitis, but no cyanosis, clapping jaundice, and lymphadenopathy. No perianal excretion seen. All the anthropometric parameter less than 3, and now the systemic examination, no abnormalities found in systemic examination. Now, what may be the possibility? We think primarily the common causes like disaccharide intolerance, celiac disease, chronic infection like HIV, or cow milk protein allergy. And kept in mind this above diagnosis, we are doing the several investigations, and the blood picture of this baby shows the microcytic hypochromic anemia with progressive neutropenia, and thrombocytopenia, and the platelet count is normal. Before the blood transfusion due to anemia, we done the HPLC to rule out the thalassemia, and 1 unit of blood transfusion is done. A stool examination shows the pH 6.8 and reducing substance absent. So the disaccharide intolerance is less likely, but the stool examination shows Giardia cyst present, but vocal blood test negative. ICTC non-reactive. Upper GI endoscopy within normal limit. Tissue transglobulin antibody is within normal limit. So rule out the celiac disease, and histopathology show the moderate villus abnormalities. The differential diagnosis of disaccharide intolerance and celiac disease, chronic infection, cow milk protein allergy is less likely for the patient, but the chronic diarrhea, anemia, neutropenia, and failure to thrive is still persisting. So now what may be the causes? And now we think the rare causes of chronic diarrhea, like primary immunodeficiency due to the chronic recurrent diarrhea, deep-seated abscess, failure to thrive, and Giardia cyst, or Soman-Diamond syndrome due to chronic diarrhea, anemia with neutropenia, and abetalipoproteinemia. As there is no history of neurological or ocular manifestation, no steatorrhea, no acanthocytes in peripheral blood smear, so abetalipoproteinemia is less likely. So we need further investigations to come to final diagnosis, like X-ray of both limb, serum lipase amylase, and serum immunoglobulin, and T cell and B cell function. As there is no abnormality in X-ray or serum immunoglobulin, serum lipase amylase within normal limit, LFT normal, no history of steatorrhea, so Soman-Diamond is less likely. This is the immunoglobulin profile of the baby that shows the IgG, IgM, and IgA antibody all are reduced, but the T cell and NK cell all are normal. At the end of the presentation, the important finding we get the decreased immunoglobulin level like IgG, IgM, and IgA, failure to thrive, and chronic diarrhea associated with Giardia infections, and also the persistence of deep-seated abscess and anemia and pneumonia, onset of all these symptoms beyond the 1 year of age. All these points favor the diagnosis towards the primary immunodeficiency, most probably due to B cell defect. And this is the pictorial diagram presenting the B cell differentiation from the mother cells of hematopoietic stem cell to production of immunoglobulin, and related primary immunodeficiency like agammaglobulinemia, hyper IgM syndrome, common variable immunodeficiency, and selective IgA deficiency. Treatment of chronic diarrhea. In fact, the treatment of cause is the main role. First, assess the hydration status and treat the dehydration if present. Antibiotics for the treatment of associated infection. Metronidazole to treat the Giardia infections. and vitamin, minerals, and nutritional rehabilitation for the severe acute malnutrition, IVIG, stem cell transplantation, gene therapy, all are considered due to the immunodeficiency, and GM-CSF for the severe neutropenia. And lastly, the lesson learned, chronic diarrhea is a great challenge which needs extensive history examination and investigations. However, a pediatrician should minimize the differential diagnosis so as to reach a different diagnosis as soon as possible. Although the most cases are benign, there are some dangerous underlying causes also. Thank you.
Madhu, I'm just seeing one question in the chat box. So elaborate F75 or F100 drug. Little bit. It's small. What you have mentioned, F75 diet. What is F75 diet?
F75 is a F75 is a special diet for the severe acute malnutrition. It is cereal based or milk based diet.
Hello.
Presentation.
Sairul.
And calorie containing 100 ml per 75 kilocalorie per 100 ml.
Kalpanadi has a question, I think. Kalpanadi.
Any question from the judges?
No, আমি একটা clarify করে দিই ওকে সাইরুলকে
Kalpanadi not hearing. Louder please.
F75, can you hear me? Hello.
F75, yes.
This is actually the term given by WHO, formula 75. F75 money formula 75, and it is usually milk based diet, not cereal based diet. As he said, the cereal based maybe it is milk based diet usually, and F100 could be milk based or cereal based. Okay, so I think any questions from any audience, any participants?
Can I ask to Khairul, what did you do for your patient? Did the patients get better with the supportive therapy, or did you have to give immunoglobulin? That's first question. Second question is, are genetic tests, will they be helpful to get a absolute diagnosis or etiological diagnosis in your patient? So first question is, how did your patient get better with supportive therapy alone, like you have detailed, or did you need to give immunoglobulin on a regular basis?
Patient cannot afford the genetic testing, ma'am. Absolute diagnosis by
okay, but what is your understanding, having read up about this case? How would it have helped? Would it have helped at all?
And please.
Immunoglobulin দেওয়া যাবে কিনা বলো? Immunoglobulin কি?
Immunoglobulin can be planned, may be considered for immunodeficiency, IVIG, gene therapy, or stem cell transplantation.
Okay, madam, I'm going to the third case. And one thing, audio is sometimes not clear. We are not able to hear all this question, madam, you are asking. Okay, I'm going to our third cases. That is another interesting case. Will be presented by Dr. Shukanna. She will be presenting a neurological involvement and approach to identify a pathological changes in the brain less commonly associated with that infection. So she will presenting in that case. I think this is a very interesting case. Shukanna will be presenting. Thank you.
Good afternoon, everyone. This is Sukanya Jana. I will be presenting on neurological involvement. Expand your suspicion. Next slide. A 3 or 6 month old male child presented in our ER in late evening with the following complaints: on and off headache for 1 month, which was about 3 to 4 times a week, relieved spontaneously, mostly in occipital region with no specific timing, not associated with nausea or vomiting, no complaints of blurring of vision or diplopia. He also complained of weakness of right hand and right foot for 1 week. It started on the right leg, which was insidious in onset, gradually progressive. Mother noticed initial slipping of slippers, followed by difficulty in walking and getting up from sitting position. Also, mother noticed he was not using his right hand with difficulty in dressing. Diffuse pain in the limbs was noted for same duration without any aggravating or relieving factors. He also had vomiting for past 2 days, which was about 3 to 4 episodes in last 3 days with non-projectile and non-bilious in nature, consisted mainly of undigested food particles. Fever for past 2 days was also noted, which was undocumented, occurring mostly at night and related with antipyretics. Among relevant negative history, there was no loss of sensation, no blood bowel involvement, no complaints of swaying during walking, no history of altered sensorium or convulsions, no history of trauma or ear discharge, no history of any cranial nerve involvement, no contact history of TB or COVID-19 patients. On examination, child was alert, conscious and cooperative. GCS was 15/15, heart rate was 100 per minute, respiratory rate 28 per minute with regular breathing. BP was 122/83, which was above 95th centile as per age and sex. Temperature was raised, SpO2 was normal in room air, no pallor, icterus, cyanosis, clubbing, edema noted. On head-to-toe examination, bilateral non-purulent conjunctival congestion was noted. On further examination, anthropocortical measurements were within normal limit. CVS chest and abdominal examination showed no obvious abnormality. Detailed neurological examination showed higher functions which were within normal limit. Cranium and spine, no abnormalities noted. No cranial nerve involvement was there. Motor examination showed muscle bulk, no wasting. Tone was decreased in right upper and lower limb, whereas it was normal in both left side. Power was 3/5 in right upper limb, 4/5 in right lower limb, whereas it was 5/5 in left upper and lower limb. Superficial reflexes revealed abdominal reflex was absent on the right side, whereas it was normal on the left. Plantar was extensor on right side, whereas flexor on left. Jux could not be lacerated on right side, but was normal on left side. No sensory involvement noted. Autonomic examination revealed no bladder bowel involvement. Gait, child was unable to walk on his own. Meningeal signs and cerebellar signs were noted. So for walking diagnosis, we had right-sided hemiplegia due to CNS infection like tuberculoma or stroke, either due to thrombosis or embolism or hemorrhage. Keeping in mind our walking diagnosis, we headed for our investigations. Hemoglobin was 13, total count was raised with polymorphic predominance, platelets was 1,50,000, CRP was raised. Other LFT and kidney function tests were within normal limit. COVID RT-PCR was negative. MANTU was negative. CVNAT report was sent, and we were waiting for the report. On day 2, patient was alert. No fever spike noted. In view of persistent hypertension, we started him on oral antihypertensive. MRI brain with EMA angiography and spectroscopy was planned. Blood for PTINR, hepatitis D-dimer sent. Echo 2D was planned. Workup for childhood stroke was done but came to be within normal limits. CSF study showed normal cell with protein sugar, no pleocytosis noted. Then child became increasingly irritable from early morning with high spiking fever. He also had 2 to 3 episodes of vomiting. No improvement in toner power noted. So as the child became increasingly irritable, we further headed for MP-MPDA, which was negative, dengue NS1 negative, blood culture was seen. All the parameters of PT, INR, hepatitis D-dimer was raised. MRI brain with EMA angiography and spectroscopy was done. Echo 2D showed no obvious abnormality. Injectable antibiotic was started to the ongoing treatment. Then on day 5, blood culture showed no growth. Scrub typhus report also came meanwhile and it was negative. So in view of persistent fever and clinical condition deteriorating, we sent COVID IgG antibody, which came to be positive in high titer. So till now we came to a diagnosis of MISC with the following supporting facts of persistent fever for more than 3 days, with bilateral non-pleural and conjunctivitis, evidence of coagulopathy, vomiting for 2 days with raised CRP, COVID antibody positive, and all other causes of infection ruled out. But the cause of hemiplegia remained unexplained, which till now we provisionally investigated as a case of hemorrhagic stroke due to hypertension. So let's see what the MRI brain shows. Now, MRI brain showed multiple ill-marginated areas of T1 hyperintensity with T2 hyperintensity with flare hyperintensity in left paraventricular region with basal ganglia region and right subcortical region. EMA spectroscopy also came in the meanwhile, which showed increased level of choline P, diminished NNFP, which favored the diagnosis of ADEM. So we reevaluated the diagnosis as a case of ADEM with the association of MISC due to COVID-19. Further, we started him on injectable methylprednisolone at the rate of 30 mg per kg per day. CSF for oligoclonal bands were planned but could not be arranged. Blood for MOG and NMO antibodies was seen and came to be negative. On day 7, child was reviewed by ophthalmological department. Clear disc margin was noted. Normal color, no features of optic neuritis noted. We started him for physiotherapy. Child became afebrile and irritability decreased. From day 8 to day 18, tone became normal. All the deep tendon reflexes of the right side were brisk. Child was able to stand without support. Power became 5/5 in all 4 limbs. Injection methylprednisolone was changed to oral prednisolone after 5 days. From day 11 onwards, child was able to walk without support and was using both hands for functional activities. So he was discharged with plan of tapering oral steroids over 6 weeks. Repeat MRI brain was planned after 3 months. EEG was awaited as per a scheduled later date. A systemic review showed neurological complications in patients with SARS-CoV-2. Here we see the nervous system involvement could be isolated, developing during COVID-19 or after its recovery, or arise in the context of MISC. Also, another reporting showed ADEM in a COVID-19 pediatric patient, a 12-year-old healthy girl child who was previously presented with skin rash, headache, and fever, but later MRI brain showed features of ADEM. In course of MISC, neurological complications such as ADEM, pseudotumor cerebral edema, seizure, cerebral stroke, and cytotoxic lesions of corpus callosum has been reported. Increased levels of cytokines disrupts blood-brain barrier integrity. Hyperinflammatory state in MISC can lead to a procoagulant state with initial vasculitis causing disruption of vascular integrity, exposure of basement membrane, and activation of coagulation cascade. So lessons learned. We can't escape the grasp of novel coronavirus in this COVID era. So it should be considered in the pathogenesis of ADEM. Clinicians treating COVID should maintain a high index of suspicion for ADEM who develop multifocal neurological symptoms. Early diagnosis and treatment of ADEM improves the prognosis for patients. So MRI brain should be obtained at an urgent basis. Few of the references that has been searched. Now, after 1 week of discharge, our child followed back in our OPD. So keep smiling while battling against COVID. Thank you.
Thank you, Sukarna. Judges, please, if there's any question for Sukarna.
Exactly, not question. Actually, ADEM following COVID is not new. Many cases has been reported.
Madam, একটু জোরে বলুন, আপনার কথা শোনা যাচ্ছে না একদম।
Actually, now it's audible. Hello, audible? Is it audible?
We can hear. Can you hear, Shubhashis?
হ্যাঁ, একটু জোরে বলুন, হ্যাঁ।
Hello. So I'm telling this is ADEM following COVID is not new. Many cases. And it has been reported from our institute, and we had a case with the resistant to immunoglobulin and Respirat. We did the PEX, and after PLEX, baby was recovered and discharged. So that is nothing new in COVID, ADEM following COVID.
Okay. ADEM following COVID is not new.
Okay, ma'am, we will take note of that.
There are a few questions from the previous presentation. 1 or 2 questions we'll be discussing from chat box. One, Dr. Shreya, the question was the thromboembolic manifestation. Is it common in COVID affected children?
Hello. Thromboembolic manifestations has been associated with COVID as well as with MISC. It is mainly venous thromboembolism, and it is more seen in COVID in adults than children. And in MISC also there's a high rise of D-dimer. Platelet count is also reduced. Maybe that might lead to the thromboembolic manifestations. And the lung sonography.
There is another question regarding is there any abnormal lung sonography finding or consolidation?
Ma'am, lung sonography or CT scan was not done in our patient, and in the X-ray we saw pleural effusion. Consolidation was not there. Ma'am, and I had searched literature and I did not find Omicron causing MISC.
Because there is another question that Omicron 2 also causes MISC, but you have searched the literature. Very few literature, or you have not got any literature suggesting the Omicron may cause MISC in children.
Dr. Shivas,
okay, I'm going to our 4th case.
This case is MISC is admitted in our hospital after Omicron. 2 cases. One is discharged, one is on ventilator.
Probably it is quite early also, isn't it, to tell, because the Omicron wave is just passing.
And in our case, we were not sure whether the previous infection was with Omicron or not. So this patient having MISC, we cannot
Yes.
Right.
I'll say that it was due to Omicron or any other variant of COVID.
Okay, our fourth case is a case of recurrent vomiting, usually classified as a cyclical vomiting. Dr. Charlene Martin is actually, she will be demystifying this vomiting case and she will break the cycle of cyclical vomiting.
Good afternoon. I am Dr. Charlene Martin and my case is recurrent vomiting, breaking the vicious cycle. So a 4-year-old female child presented with acute onset vomiting and extreme lethargy for 2 days. Vomiting was associated with nausea, consisted mostly of mucoid material mixed with some partially digested food particles. There were 15 to 20 episodes in a day and child became extremely lethargic by the second day. This was not associated with abdominal pain, fever, diarrhea. On clinical examination, some dehydration was present, mild tachycardia and mild pallor was noted, otherwise vitals were stable. Abdominal examination was found to be normal. ABG showed significant metabolic acidosis with reduced bicarbonate. Now, this child had similar multiple episodes starting from 2 years of age, usually associated with mild cough and cold. Initially, episodes occurred at intervals of around 6 months. However, for the last 1 year, these episodes occurred at 1 to 2 months interval. In each episode, there was so severe vomiting and significant metabolic acidosis that the child required admission. She also complained of burning sensation in palms and soles just prior to these events. And during each episode, it usually resolved in 1 to 2 days after intravenous fluid resuscitation. Child used to be completely symptom-free in the interval between the 2 episodes. During one such episode, hyperglycemia was noted and child was managed in the lines of diabetic ketoacidosis. But hyperglycemia and ketosis resolved completely by 3 days and no prolonged insulin therapy was required. Our patient was born of non-consanguineous marriage. She was a term baby of 2.7 kg. There is a history of death of elder sibling who had similar episodes starting from 18 months of age. This sibling had expired at around 4 years of age due to severe bleeding. No documents could be produced by the parents. We kept these differential diagnoses in our mind based on the history and clinical examination. Malrotation with volvulus, chronic gastritis, acute hydronephrosis secondary to PUJ obstruction, Addison's disease, metabolic disorder, abdominal migraine, migraine disorder, neoplasm, metabolic encephalopathy, and cyclical vomiting syndrome. Keeping these differentials in mind, we proceeded with the investigations. The CBC, CRP, LFT, RFT was all within normal limits. USG, whole abdomen, upper GI endoscopy, EEG, and MRI were normal. No abnormalities could be detected. However, ammonia and lactate were found to be borderline high. We revisited a differential diagnosis to evaluate what are the possibilities we could rule out. GI and GU abnormalities were ruled out because imaging studies were normal. We ruled out Addison's disease because electrolytes were never deranged and child never presented in shock. Neurological possibilities were ruled out as EEG and MRI showed normal study. So our working diagnosis boiled down to metabolic disorder and cyclical vomiting syndrome. Cyclical vomiting syndrome is diagnosed based on minimum 5 attacks in any interval or minimum 3 attacks in a 6-month period. Episodic attacks of intense nausea and vomiting lasting 1 hour to 10 days, occurring at least 1 week apart. Stereotypical pattern and symptoms in the individual patient. Vomiting during attacks occurs at least 4 times per hour for at least 1 hour. Return to baseline health between episodes and not attributed to another disorder. Our child fit the criteria for this diagnosis. However, in view of the red flag signs, such as history of death in sibling with similar symptoms, metabolic acidosis, reduced bicarbonate, and ammonia and lactate being high, we planned TMS and GCMS for this patient. The reports came back as positive. Urine showed increased levels of isovaleric carnitine. Blood had increased level of 3-hydroxybutyric acid, increased hypoxanthine, and isovaleric glycine. These findings were suggestive of isovaleric acidemia. Gene sequencing was sent, and the report showed mutation in the IVD gene. So we could arrive at a final diagnosis of isovaleric acidemia. Isovaleric acidemia is a condition in which there is a defect in the metabolism of leucine. There is deficiency of isovaleric-CoA dehydrogenase, which leads to accumulation of metabolites, isovaleric carnitine, isovaleric glycine, 3-hydroxyisovaleric acid. These are detected in body fluid and helps us to arrive at the diagnosis. For the management of this child, we started her on L-carnitine. Counseling was done regarding low leucine diet. Patient was symptom-free for 3 months, then presented with vomiting. However, in this case, the episode was milder in comparison. The lesson learned was that in a case of severe symptoms leading to multiple hospital admissions compounded with history of similar episodes and death in elder sibling should give rise to suspicion of metabolic disorder. IM should be considered as one of the possibilities and investigations planned accordingly. Cyclical vomiting syndrome is a diagnosis of exclusion. All other possibilities should be thoroughly ruled out before arriving at this diagnosis. Nelson says that in the chronic intermittent form of the disease, the first clinical manifestations might appear when the child is a few months to few years old. In both forms, acute and chronic metabolic decompensation may occur during a catabolic state such as infection, and acute episodes may be confused with decay. This is a case report of a 2-year-old boy who had presented with multiple times of vomiting, metabolic acidosis, and hyperammonemia, ultimately diagnosed with isovaleric acidemia. And this is a case of 8-year-old child who had recurrent acute pancreatitis, who was ultimately diagnosed as isovaleric acidemia. Thank you.
Charlene, one question from the chat, that what do you mean by low leucine diet?
Low leucine diet are all those foods which have leucine in small quantities, such as barley, rice, wheat. These all has 0.6 to 0.7 gram per 0.6 to 0.7 gram of leucine per 100 gram of food. In vegetables, she was recommended cabbage, lettuce, brinjal, capsicum, cauliflower, all this. Fruits, generally she can eat all of the fruits. Nuts such as almond and walnut, she was advised to take in small quantities, and grams, Bengal gram and rajma, these usually have around 1 gram of leucine per 100 gram. So she was advised to take this in small quantities. And as protein sources, button mushroom and milk was mainly considered because chicken and egg also has 1 gram per 100 gram of food. Thank you, ma'am.
Judges, if you have any question for Charlene?
Okay, is it
or should I go to the last, our fifth case?
Okay.
Can I ask Dr. Shubhashish, very nicely
Yes,
presented, Dr. Charlene, and I think it's nice to have a completion and a definitive diagnosis at the end. Can you just enlighten us what is the long-term prognosis for these children?
Ma'am, on long-term prognosis, taking care of diet is the mainstay of treatment. If we adequately, if the child can adequately follow low leucine diet, there will be milder symptoms. Our child is on follow-up for 1 year. She has presented twice at an interval of 6 months, and these times she was milder because earlier she would be more lethargic and acidosis used to be more severe. And it has also been seen that if we can start on L-carnitine, that also helps.
So these episodes are precipitated by infections and mild infections, etc. These episodes of vomiting.
These can be set on by mild infections. Our child usually had mild cough and cold before she presented with the severe symptoms, and the last time that she was here, she had a COVID infection.
And long-term neurological symptoms, anything? Neurological development is usually normal in the long term?
No, ma'am. Her developmental milestones are normal and her anthropometric measurements are also normal.
Okay, thank you.
One question, one more question.
One point to come in.
Yes, sir.
Can you hear me?
Dr. Dotto, আমি একটা question করছি.
Yes, sir.
Can you please explain what could be the presentation? What could be the explanation of the presentation of hyperglycemia with decay?
Presentation of hyperglycemia. Hyperglycemia with decay presentation therapy.
The child was lethargic, had acidotic breathing, her CBG was high, and Sir, child had acidosis, dehydration, and hyperglycemia.
Hyperglycemia. Okay.
Okay, I'm going to our fifth case. The next case is a pallor in a 2-month-old baby. Dr. Swastika, our PGT, will unfold a progressive pallor with the interacting pathogenesis and how the final diagnosis was made and treated. Swastika, please.
Myself, Dr. Swastika Ghosh. I am going to present a case of anemia in 2-month-old baby. 1 month, 20 days old female child presented in our emergency with complaints of refusal to feed and decreased activity for 1 day and vomiting for 1 day, which was non-bile or blood stained, non-projectile in nature. No history of abdominal distension, blood in stool or diarrhea. No history of fever, convulsion or decreased micturations. On examination, the child was lethargic, cry, response, activity, tone was poor, and sucking was poor. All the vital parameters was within normal limit, but the baby was significantly looking pale, and weight, length, and head circumference all are below 3 standard deviation. On systemic examinations, cardiovascular system and respiratory system was within normal limit. Per abdomen was soft, liver was palpable 3 centimeter below costal margin, span was 6 centimeter, which is firm in consistency with some margin and non-tender. Spleen was palpable 4 centimeter below costal margin, soft to firm in consistency. There was no free fluid in abdomen and intestinal peristaltic sound was present. Other significant history reveals mother had a fever with rash in the first trimester of pregnancy and baby was born through normal vaginal delivery. There was twin delivery born at 32 weeks of gestation. Birth weight was 1.1 kg. At presentation, the weight was 1.3 kg. So there was a 4 weight gain. Baby was admitted in SNCU for respiratory distress syndrome. And there is history of death of the second twin at the 15 days of age due to the respiratory distress syndrome, and baby was on formula feeding with improper dilution. Now, the possibilities came into our mind is late onset sepsis and congenital infections because the mother has a history of fever with rash in the first trimester and baby had a hepatosplenomegaly. We immediately checked the blood glucose and electrolytes, which was within normal limit. And keeping in mind the possibilities, we sent CBC, CRP, blood culture, urine for routine and microscopic examinations, CSF examinations, and torch panel. And baby was started with IV fluid and empirical antibiotics, piperacillin, tazobactam, and amikacin. On day 2, there was no further vomiting, so orogastric tube feeding was initiated. Meanwhile, the investigation report shows there was anemia with thrombocytopenia and CRP was raised, and CSF examination shows protein was elevated and sugar was decreased, which is suggestive of meningitis. On day 3, the baby is looking more pale. Because of that, CBC with peripheral smear and reticulocyte count was sent. And report shows the hemoglobin 7.2 gram percent and platelet 45,000. And peripheral smear RBC shows mild to moderate hypochromia, and there was no parasites. And reticulocyte count was within normal limit. Because the hemoglobin level falls below 7.5 gram percent, PRBC was transfused at a rate of 10 ml per kg. Meanwhile, in day 5, blood CS reports arrived which shows growth of the Staphylococcus hemolyticus, and antibiotics were modified according to the sensitivity pattern and planned for 21 days as CSF suggestive of meningitis. On day 6, again, as the baby was looking more pale, CBC was sent, which shows the hemoglobin was 6.9 gram%, because of which PRBC was transfused. And as the 2 transfusion was required, serum ferritin was sent to which came within normal limit. Again, on day 8, as the hemoglobin was fall again required the PRBC transfusion. The baby have the present issues of progressive anemia, which require repeated blood transfusion, persistent thrombocytopenia, and hepatosplenomegaly. And during hospital stay, the liver and spleen size increases than before. The possibilities came into our mind is hemolytic anemia, congenital infections, and fungal sepsis, because the baby was premature and prolonged hospital admission, and there was persistent thrombocytopenia. However, history was reviewed to rule out the hemolytic anemia, and HPLC of the parents and other differentials of the hemolytic anemia were sent, which appeared normal, and torch panel was sent before the report was awaited. And to rule out the fungal sepsis, blood culture was repeated and started empirically with antifungals injection voriconazole. Meanwhile, the torch panel report shows the baby has CMV IgM positive. Then urine for CMV DNA PCR was sent. Meanwhile, the blood culture shows no fungal growth and injection voriconazole was stopped. Urine for CMV DNA PCR shows 70,000 copies. And till now, we diagnosed as a case of congenital CMV infections. CMV related investigations were done. Ophthalmological evaluation shows no evidence of chorioretinitis. Ear examinations was within normal limit. And brain imaging, USG and MRI, there is no features of the CMV infections like ventriculomegaly or periventricular calcification. Should we start ganciclovir in these cases? Indication of treatment in congenital CMV infections, infants with CNS manifestations, chorioretinitis or systemic disease like pneumonitis or hepatitis. None of this was present in our case, so ganciclovir was not started. However, in view of repeated blood transfusion, that is 5 transfusion was required in the span of 14 days, patient was sent for hematological opinion. And by the hematological department, we are advised to do the CBC and PBS again. Repeat PBS shows trophozoites of Plasmodium vivax, and we started the patient with syrup chloroquine according to the protocol. And a PBS was repeated after the 3 days of the initiation of the treatment and shows no parasites, and hemoglobin was 11.1 gram%, and there was no thrombocytopenia, and liver and spleen size was decreased. Finally, the baby was discharged at an age of 2 months, 15 days, weighing 1.9 kg. We arrived at a final diagnosis of late onset sepsis with Plasmodium vivax malaria with congenital CMV infections. Anemia, thrombocytopenia, and hepatosplenomegaly, it can be due to the CMV infections or malaria, but it may most probably due to the malaria, because after the treatment completed, anemia and thrombocytopenia was not there, and baby was kept on follow-up for CMV infections, and there is no recurrence of the liver and spleen size was decreased, and no recurrence of the anemia and thrombocytopenia. Could it be a congenital malaria? Congenital malaria usually acquired from the mother in the prenatal and perinatal period, and parasites usually demonstrated in the peripheral smear within 7 days of life. And usually the maternal history of malaria present in the late pregnancy, and signs and symptoms appear between 10 to 13 days of the age, and signs and symptoms includes fever, restlessness, drowsiness, pallor, hepatosplenomegaly, jaundice, poor feeding, vomiting or diarrhea. But in our case, there was no history of malaria of mother during the pregnancy, so it is unlikely to be congenital malaria. However, it is not possible to differentiate between the congenital malaria or postnatal infections in endemic region. From our case, we learned that malaria can be missed in neonatal period or early infancy because of the overlapping symptoms with other illnesses like sepsis and congenital infections. And previously the malaria parasites was not detected in initial smear. It might be due to the lower parasite densities. So whenever newborn or young infants presents with unexplained pallor, thrombocytopenia and hepatosplenomegaly, malaria should be kept as a differential in endemic region. Thank you.
Hi, Dr. Shivashish. Hello.
Bolun.
Sensorineural
Yes.
deafness rule out kora jay? Did you rule out the sensorineural deafness that is quite common with CMV infection, congenital?
OAE was done and it was normal.
Okay. Sometimes it may be, it is a screening method, no?
Data was planned in SSK.
So there is another question in chat box. So what is the long-term prognosis of this baby?
Child does not having any manifestation of the congenital CMV infections. So the prognosis is good.
At time for the malaria, how the patient, when you patient came for the subsequent visit, everything was otherwise normal or not? Growth and all these things.
Child have a good weight gain and developmentally within normal.
Another question: have you used primaquine for this baby?
No, it is primaquine is not used because it is contraindicated in infants below the 6 months of age.
Any other question, madam? Hello, then I'm going to our last case. The last case is a final case with a AES, acute encephalitis syndrome, will be presented by Dr. Jyotirmoy, and Jyotirmoy will take us into a journey of clinical crossword to relatively identify a unique pathogenesis of this clinical condition, which is highly manageable and salvageable. Jyotirmoy, please present your case.
Good afternoon, everyone. I am Dr. Jyotirmoy Ghosh. Today my case is acute encephalitis syndrome. Do not forget the common bug. So the chief complaint of the patient was a 6-year-old boy with fever for 7 days, continuous in nature, not relieved by medication, and was associated with body ache. There was non-projectile type of vomiting for 5 days, and in the course of 7 days, the boy had a progressive increase in body ache with increased unresponsiveness and somnolence. When the boy came to our emergency ward, the boy was examined and to have a GCS of 7 out of 15. Pupils were checked. The right side pupil was non-reactive to light. The left side was sluggishly reactive to light. Heart rate was there 52 per minute. That is a bradycardia. Respiratory rate was jerky and it was 10 per minute. Pulse was hypovolemic, TREDI, no radial or radiofemoral delay. BP was 130 by 80. That was near about 90th percentile for age. Chest finding shows bilateral vestibular breath sounds with clefts. Neurological examination on day 1 showed the baby was not responding to any kind of vocal commands or any stimulus. So the GCS was 7 out of 15. There was no signs of meningeal irritation. Cranial nerve examination was not possible, except the second nerve was examined. The pupillary reflex was absent. Bilateral pupil was fixed and non-reactive to light. Fundoscopy was done. Fundoscopy showed grade 3 papilledema. Motor examination was done. Power in the both upper and lower limb was grade 0. Tone was increased, a spastic type of tone was there. Deep tendon reflex was exaggerated in both upper and lower limb. Babinski sign was positive. So the day 1, the boy was treated in the line of acute encephalitis syndrome. Because there was fever with altered sensorium, there was features of raised ICT. Accordingly, drugs were given and started on inotropes and was put on invasive mechanical ventilation. Treatment was started with meropenem, vancomycin, and doxycycline. Antiviral acyclovir was given. 3% SL was started for the raised ICT, and anti-epileptic phenytoin was started. Initial investigation investigation of electrolyte sodium and potassium was normal. Hemoglobin was 10.8. CRP was raised, was 83. CBG was 102, and MPMPDA was negative. So the investigations arrived on day 2. The investigation showed that there was leukocyte with polymorphic predominance. LFT was normal, but there was hypoalbuminemia. Urea creatinine was within normal limit. Due to raised ICT, lumbar puncture was not performed. The fevers that was there had subsided on day 2. Now the subsequent reports, the scrub typhus IgM came negative, so we stopped the doxycycline. Dengue IgM came negative. Chikungunya IgM also came negative. CSF for JE virus IgM could not be done because there was raised ICT. So ultimately, Mantoux test and a CB-NAT of gastric aspirate was sent, thinking of a tubercular etiology. So at in the day 4 to day 10 course, the Mantoux test was interpreted negative on day 5. The patient needed a prolonged ventilation, invasive ventilation. So tracheostomy was done on day 8. CB-NAT report came out to be negative on day 9. And brain imaging was not possible because the boy was on invasive ventilation and there was no imaging facility available in your institute. So keeping demyelinating disorder as edema is a possible cause. So we started the patient on injection methylprednisolone in a pulse dose of 30 mg per kg per day, and it was given for 5 days. In this course, the features of raised ICT persisted, and we increased the dose of 3% SCL. So in the next subsequent 11 to 15 days, the features of raised ICT was there. So we started on mannitol and hyperventilation was done. Neurological examination showed further increase in tone and further increase in the spasticity in the lower limb. The boy was shifted from invasive to the non-invasive ventilation and was hemodynamically stable on day 14. So being hemodynamically stable, we started the boy on RAS tube feeding and slowly we tapered down the inotropes. But fact that on day 15, the boy again developed a fever that was high grade in nature and it was continuous. If that even subside on giving appropriate kind of antibiotics. So after the subsequent days, the boy was given trial by TPs with moist oxygen, but the boy deteriorated neurologically. The new incident that occurred was the formation of pus in the tracheostomy site with pus in the central venous line also, side also. The right side femoral catheter was removed and the new left side central venous line was done. Blood culture and tracheal aspirate were sent. In this course, the patient developed euvolemic hyponatremia, so fluid restriction was done, but still the high-grade fever persisted. So the neurological examination on day 20, the child was responsive minimally to some pain stimulus and was responding to vocal commands, but inappropriately. The DCS was 9 out of 15. There was no meningeal sense. Cranial nerve examination could not be done, but the papilloedema persisted. In motor examination, power was grade 1 in both upper and lower limb, but the tone further increased, showing a clasp knife kind of spasticity. There was findings of involuntary movements. The reflex were exaggerated in both upper and lower limbs. But here we found a new finding as ankle pronus was present in the lower limb. In the day 21 to 25, the blood culture report came as to be no growth was present. Tracheal aspirate showed growth of organism as S. multifilli and was given appropriate sensitive antibiotic, that was levofloxacin. But even after giving subsequent antibiotics, the fever didn't subside, even the pus didn't subside. Recurrent suction was needed from the tracheostomy side, and pus started developing on the left side at central venous axis also. But the examination showed that the patient was improving hemodynamically. So we performed the MRI brain in a nearby facility, which showed the following findings that are given by arrows. Here we are getting to see basal exudates and hydrocephalus. So we reviewed our diagnosis, and on meticulous reviewing of the patient's past history, medical history, that revealed that the boy's father had a history of tuberculosis, which was initially concealed and denied by the patient party. He was also a treatment defaulter. The MRI brain reveals that it's an acute communicating type of hydrocephalus with enhancing basal exudates, periventricular seepage of CSF was there, possibly a tubercular etiology. So this is the report that we got from the radiologist. So seeing this report and the clinical history from the patient party, we started the patient on a CNS regime of anti-tubercular drugs along with the steroid injection dexamethasone. So after giving the drug from day 22 to 28 to 40, the boy showed clinical improvement, fever and pus formation subsided, neurological examination showed improvement with increased consciousness and alertness, decrease in spasticity, improve in muscle power. So subsequently tracheostomy decolonization was done, and we are planning the patient for discharge. So neurological examination on day 40. The child became conscious, fully responsive to vocal commands, a GCS of 40 out of 15. No meningeal involvement. Cranial nerve examination. Pupillary reflex was normal. Fundoscopy showing no papilledema. Eyeball movements were normal. No facial muscle weakness was there. Power on the upper limb was grade 4. On lower limb was grade 3. There was decreased spasticity in both upper and lower limbs. No involuntary movements. Deep tendon reflex showed no normal response, and plantar became flexor. So this is the course. On day 8, the patient was on immersive ventilation, and on present day, the boy is sitting on the chair. So what is the lesson learned? Meticulous history taking, good clinical examination, broadening of thoughts helps to reach a diagnosis of a disease process. Anti-tubercular drugs are still the miracle and the hope to treat extrapulmonary tuberculosis. Unusual presentation as high-grade fever and pus-like material formation occurs in tuberculosis, and that responds to ATT. Thank you.
Thank you, Jyotirmoy, presenting this case. So if there is any question from the judges.
No question, but thank you for presenting nice cases, and all cases are very interesting, compiled nicely and presented nicely. Thank you from my side.
So my sincere thanks to all WBAP member, president and secretary, and also our president-elect Dr. Kalpana Datto, and the judges for today. And I must thank our faculty who actually helps a lot for, to prepare this case for the PGTs. And I must thank all our PGTs in spite of difficult time, in spite of the surge of this epidemic. They ultimately prepared all these cases and presented in the West Bengal AP meeting. Thank you everybody. So if there's a, I think our respected judge will announce the case of the day or results for today presentation.
Dr. Kalpana, you please announce the result.
The marks already given to President. She will going to
shall I announce? Okay.
Yes.
Okay. So the judges have decided Dr. Charlene Martin first and Dr. Shreya Mukherjee second. Congratulations to Dr. Charlene and Dr. Shreya, but congratulations really to all of you, to all those who presented, and to all the faculty who worked very hard to make such an interesting presentation in this clinical meeting. Thank you.
Thank you.
Indranil, closing comments?
Thank you, everybody, all the faculty and the students who has done the clinical meeting today with fluent scientific knowledge. And the judges, thank you very much for being present here for the first time in this year. And myself and Dr. Sushmita Banerjee, I think we should close the clinical meeting today. Thank you.
I think we should have, like we used to have during our physical meetings, we should have certificates that we will hand over. Right, Indranil?
Yeah, we'll
so they will get e-certificate.
Either e-certificates or we can print out certificates and hand them over to one of you.
This year we were not prepared with the judgment part. So yes. I think in the next meeting onwards, we will have quite a good protocol for it, and also what to be given to the students.
But in Indranil, I think they will get a certificate then also. If for the next meeting, they will get a e-certificate, if not possible by hard copy. If they can get some e-certificate, that is online certificate, that will be very encouraging for them also.
No, sir, we'll give hard copy certificates to the CSS faculty so that they can get it.
Okay.
And hopefully we will be able to move on to physical meetings in the near future, which will make all this much easier.
Okay.
Thank you so much. Thank you.
Thank you everyone.
Thank you everyone for